Let's talk about galactorrhea, types of types and causes of nipple discharge. You have just lactation. Then you have physiologic nipple discharge or galactorrhea. Then you have pathologic nipple discharge. For lactation, this is just normal secretory product during pregnancy and postpartum period. Can last 6 months even after cessation of breastfeeding. For physiologic nipple discharge is non-pathologic and unrelated to pregnancy or breastfeeding. Usually is bilateral and white or clear. Can be unilateral and other colors such as yellow, green, gray, but it's never bloody. Common causes of hyperprolactinemia, medication, pituitary tumors, and other endocrine abnormalities. Then you have the pathologic nipple discharge. They're usually unilateral, single duct, persistent, and spontaneous. They can be serous or serosanguinous or just bloody. Common causes are 50% papillomas, which is benign, but sometimes they can have underlying cancer. Duct ectasia, which also is benign. So papilloma is 50%, duct ectasia is 30%, 15% is cancer, and very small amount is infections, 5%. Clinical evaluation, obtain a history. Physiologic discharge usually is bilateral and multiductal. Can occur with breast manipulation, and other associated symptoms include irregular menses, infertility, visual disturbances, and headaches. Risk of cancer is higher when the discharge is spontaneous, bloody, unilateral, uniductal, associated with a breast mass, and if the patient is over 40. Recent onset of amenorrhea or symptoms of hypogonadism, then we should think about hyperprolactinemia, medications that can cause galactorrhea, antipsychotics such as chlorpromazine, haloperidol, risperidone, amitriptyline, antidepressants, citalopram, fluoxetine, paroxetine, sertraline, and bupropion, antiemetics, metoclopramide, and prochlorperazine. Prochlorperazine. Physical exam. We should note any skin changes. We should have a skin punch biopsy if suspicious of patches. We should also try to elicit any discharge around the areola. Try to feel for enlarged axillary or supraclavicular lymph nodes. Diagnostic evaluation for physiologic discharges. We should obtain an HCG, prolactin, creatinine, because prolactin is secreted in the kidney, and TSH. For pathologic discharges, lab tests for galactorrhea is not indicated if there is suspicion for pathologic nipple discharge. Diagnostic mammogram and ultrasound. If patient is 40 plus, we should get both diagnostic mammogram and diagnostic ultrasound. Between 30 to 40, it should be a diagnostic mammogram first, followed by breast ultrasound if needed. Less than 30, ultrasound first. Ultrasound can see pathology as small as 0.5 millimeters. 0.5 millimeters? Or 0.5 centimeters. Can pick up 70% of ultrasound, 70% of lesions not seen on mammogram. Less specific in differentiating between benign versus malignant. If negative mammo and ultrasound, then we can get an MRI. 20% of pregnancy in second or third trimester can see bloody nipple discharges. Usually there is hypervascularity of the developing breast. However, if the bloody discharge persists, then we should get an ultrasound. In women with nipple discharge at risk of malignancy, less than 40, only 5%. 40 to 60 is 10%. 60 plus is 30%. If they have nipple discharge, the risk of malignancy is this. Causes of hyperprolactinemia, physiologic. This is the causes of hyperprolactinemia. Physiologic is meals can increase prolactin up to 50 nanograms per milliliter in premenopausal women and 40 in postmenopausal. Pregnancy prolactin is at the highest at delivery, then it starts to go down even if you're breastfeeding. So first week of postpartum, it can go up to 300 nanograms per milliliter due to suckling. However, at several months, even the suckling can only increase prolactin above baseline by around 10 nanograms per milliliter. Stress can also increase prolactin level. However, it rarely exceeds 40 nanograms per milliliter. Pathologic causes lactotroph adenomas or prolactinomas. These consist of 40% of pituitary adenomas, can sometimes be part of multiple endocrine neoplasia type 1 or MEN1 syndrome. It is size dependent, less than 1 centimeter, usually associated with prolactin level less than 200 nanograms. 1 to 2 centimeters, it's usually between 200 to 1,000. Greater than 2 centimeters, you can see 1,000 plus nanograms prolactin level. Compression of the optic chiasm can lead to bitemporal hemianopia. Decreased dopaminergic inhibition of prolactin This is another cause of hyperprolactinemia. So if there's a damage to the dopaminergic neurons of the hypothalamus, such as pituitary stalk section from trauma, drugs that block the dopamine receptor on lactotroph cells, as above mentioned over here, antipsychotic, antidepressants, and antiemetics. Another cause of hyperprolactinemia, disease in or near the hypothalamus or pituitary that interferes with secretion of dopamine, such as tumors of the hypothalamus, such as a craniopharyngioma. Then you have section of the hypothalamic pituitary stalk due to trauma or surgery. Other causes, estrogen, hyperestrogenism, hypothyroidism, or kidney disease. Management of hyperprolactinemia, existing or impending neurologic symptoms due to size. So if it is a macroadenoma, 1 cm or more, this is usually treated due to likelihood of causing mass symptoms. Less than 1 centimeter, 95% of them do not enlarge. Hypogonadism or other symptoms. So when do you treat hyperprolactinemia? If they have existing or impending neurological symptoms due to size, if the patient experience hypogonadism or other symptoms, if they have menstrual cycle dysfunction, then you will treat them. So we talked about the size one, hypogonadism. If the serum prolactin is greater than 100 nanograms, it is associated with amenorrhea and low estradiol, which can lead to bone loss. If the level is between 50 to 100, this can lead to amenorrhea or oligoamenorrhea. If the level is between 20 to 50, this can cause oligomenorrhea and infertility due to insufficient luteal phase progesterone secretion. Galactorrhea itself is a symptom. No need to treat unless it is bothersome to the patient. So menstrual cycle dysfunction is another reason to treat. Treatment options, usually first line is dopamine agonists. They are first line for all hyperprolactinemias of all sizes. It can shrink the size and decrease prolactin in 90% of patients. Cabergoline is first choice. They are less likely to cause nausea. You can start 0.25 to 0.5 milligrams per week up to 3 grams per week. Usually start 0.25 twice a week. You can use this even if the patient is trying to get pregnant. Bromocriptine is second line You can do 1.25 to 2.5 milligrams daily. Typical side effects include nausea, postural hypotension, mental fogginess. This needs to be titrated up slowly.